This is Dr. Howard Strassler presenting the E-lecture on Posterior Composite Resins, Module E, Class 2 Preparations and Restorations. And as you can see from the images on this opening slide, on the left-hand side we have a Class 2 composite, defective, it's broken, it's been fractured at the marginal ridge, the composite's been removed and replaced. And you can see how well contoured and anatomic the proximal contact is and the placement of the marginal ridge. And on the right hand side, if you look at the radiograph of this Class 2 restoration, that it's mimicking the contour of the anatomy of the normal tooth. The interventions for Class 2 composites are generally dependent upon whether or not there's caries on the surface or a defective restoration. We might be using an occlusal access with a proximal slot preparation with an occlusal sealant, or we might even use a facial access for a very small, minimally invasive restoration. When the interproximal caries is also on the occlusal, or there's a defective restoration on the occlusal, it'll in fact look like an amalgam Class 2 preparation. And keep in mind, for Class 2s, we might not necessarily be doing a composite, but we might in fact be doing a composite inlay or an onlay, or a ceramic inlay and onlay. One of the main rules that we try to abide by, besides good isolation with the dental dam, is if the gingival margin ends up being at the level of the gingiva or below, then we must consider another restoration choice. We know that the gingival margin of a Class 2 is high risk, and that placing a direct placement composite with poor isolation, even with a matrix in place, is not going to be successful. We see the replacement rate of Class 2s being 3.5 times greater than that for amalgam. And certainly the placement of the light and light curing becomes very critical in terms of the duration of light curing. Our preparation design for our Class 1 and Class 2 direct composite resins utilize a 245 or a 330 burr. In the case of a very deep proximal box where we can still get the isolation with the dam, we might be using a 556 cross-cut Fisher burr. The preparation can be an amalgam replacement. It can look like an amalgam preparation. When we're replacing a defective restoration, the outline is going to be determined by the replacement of the restoration. The occlusal cavo surface margins are at right angles with no bevels. This is a stress-bearing area. We don't bevel stress-bearing cavo surface margins. If we bevel a stress-bearing cavo surface margin, the composite will be susceptible to premature fracture. Also, our occlusal outline and our depth of preparation, as with a Class 1 composite, our preparation does not have to be interdentin. It's only defined by the extent of the caries, similar to a preventive resin. In fact, you can be doing a preventive resin and a slot preparation together. The outline for the proximal surface is determined by the caries extension. Class 2 composites do not need to break buccal or lingual contact. We can still have proximal contact of the buccal and lingual walls. It usually breaks the gingival contact because the initiation of the decay is generally right below the contact area. We can also have the proximal contact to be visually open or still in contact at the height of contour. Either buccal or lingual can have contact and the other side can have an open contact. That contact helps determine the type of matricing we'll use for the placement of the composite. When we have proximal caries with no occlusal caries, we can do a slot preparation. We may or may not place a sealant on the occlusal depending upon caries risk. Or we can even do a facial approach for a preparation where we see proximal caries. It doesn't involve the marginal ridge or the occlusal surface. Here we're looking at a variety of different preparation designs. Here we're looking at a conventional preparation with a full occlusal, but the proximal contact buccal and lingual hasn't been broken, but the gingival contact has been opened up and is visually open. Here we're looking at another conventional Class II composite preparation with a full occlusal, and we've broken contact both buccal and lingually and gingivally, and we can visually see that the contact is open. Or here, a removal of an amalgam restoration, and we have a conventional Class II composite preparation. It looks exactly like an amalgam preparation. Breaking contact buccal lingually, we're 0.5 millimeter into dentin. We've broken contact gingivally. Or for this circumstance, where we see radiographic caries on the distal and number 20, we can see the shadowing through the marginal ridge, and we have an occlusal staining which may or may not be caries. Our preparation, we decided to open up and remove, and you can see how extensive the caries was, and in fact there was caries on the occlusal as well. We've broken contact buccally, lingually, and gingivally with a more conventional Class II preparation. In this circumstance, we see distal caries, but there's no occlusal caries on this tooth. The marginal ridge is fractured out. We anesthetize the patient. We place wedges to pre-wedge the teeth to get rapid separation. You might remember those concepts in the first year lecture series. We've made a slot preparation where the gingival contacts barely open, and in fact in this case the buccal and lingual contacts were open as well. Or this slot preparation where the gingival contact is open. You can see the Class II caries on the radiograph on tooth number 5. You can see that I still have proximal contact on the buccal and the lingual, but the gingival contact is open. Our composites, as we've mentioned before, are our nano-hybrid micromatrix hybrid TPH3, our nanomatrix nanohybrid aesthetics, and our packable Quicks composite. If we're doing a PRR, we'll be using Virtuoso Flowable as a flowable composite. Class IIs present a unique problem. When we're placing a Class II amalgam with a matrix band, we can make the amalgam denser. We can pack it in. We can pack it up against the matrix. Composite resin is a viscous liquid. It cannot be pushed against the matrix band, and so we need to use specialized techniques to attain proximal contact. To achieve proximal contact, we're going to use specialized techniques and devices. We need to pre-wedge the preparation before we start it. We anesthetize the patient, place the dental dam, and we place a wedge. We place the wedge firmly between the teeth. That wedge is going to give us rapid separation between the tooth that's going to be restored and the adjacent tooth. That's going to help us compensate for thickness of the matrix band. We can use separating rings with sectional matrices. We've used the Paladin matrix with the bitine ring. The ring actually forcibly pushes up against the adjacent tooth, causing rapid separation. We can use a dead soft metal matrix band that looks like a Toffemeyer matrix band, but it's much thinner. It has a thinness of 0.001 inch in thickness, as compared to our conventional Toffemeyer band has a 0.0015 inch in thickness. The dead soft metal requires that we break proximal contact, and I'll refer to that as we look at a variety of different cases. When you're selecting a sectional matrix or a dead soft metal matrix band that's like a Toffemeyer, the Ho band, you must break proximal contact buccal, lingual, and gingival. These very thin, flexible bands will not go between the teeth. A regular Toffemeyer matrix will go between the teeth. If you're not breaking contact buccal and lingually, you use a conventional matrix band because you still have contact between the teeth. So let's take a look at several cases. Our diagnosis is number 20 has a distal occlusal carious lesion where we can see there was fracture of the distal marginal ridge. We've anesthetized the patient and we've pre-wedged the teeth. Wedges are placed mesial and distal, and the reason there's placed mesial is I'm going to be using a hoe band, and in order to get to break contact to allow me to place the matrix band, I need to place wedges. I'm creating rapid separation by pre-wedging the class 2. I always pre-wedge class 2s with or without breaking contact. It's removing and moving the dam out of the way interproximally. It's giving me rapid separation. Remember, placement of composite doesn't allow me to make a denser composite. It's a very viscous liquid. And it's similar to when you sit into a bathtub of water. When you sit in the bathtub of water, the water rises, Archimedes' principle. The same thing when you place an instrument in composite, the composite will rise up on the sides. Here's my slot preparation. Gingival contact's broken. Buccal and lingual contact are broken. There's no need for the placement of retentive grooves. Our adhesive will keep the restoration in place. When you're doing slot preparations, it's critical that you extend the outline to visualize all the caries. One problem that we see with novices, beginners on placing class 2s is they keep the outline very narrow, and they don't see where the caries has extended, nor can they remove the caries. So to fulfill convenience form, we need to make sure that the outline's extended to make sure all cavity walls are caries free. Here we are looking at a hoe band. It is a dead soft metal matrix, 0.001 inch thin. It's what we can use for MOD posterior composites, DO or MO composites, as long as we can apply the matrix. I now etch the tooth in the preparation for 15 seconds. I then rinse it and dry it from the tooth. I'll place Optibond Solo adhesive, I'll air thin it, and then I'll evaporate off the solvent. I already have my matrix in place before I place my adhesive. Critical points when curing posterior composites. It's important that we air thin the adhesive and light cure the adhesive separate than the composite. We want to hold the light 1 millimeter or less from the restorative material and at right angles to the restoration. For a premolar, the light diameter is compatible with light curing, but for molars you may need to have to overlap the light. Curing time of at least 20 to 30 seconds in the proximal box for the class 2. You can't overcure. The light tip must be in line with the area being cured. For a class 2, cure the proximal box, then move the light and cure the occlusal for a molar. The diameter of the light determines if you need to move the tip to cure the entire occlusal and proximal surfaces. You'll be receiving instructions on the LED curing wand for the clinics, our plug-and-play Sadilec mini LED when you enter the clinic. You want to hold the light as close to the tooth as possible. Here the light tip is at right angles and touching the matrix band. You want it to be as close as possible, and you want to use an extended curing time. You don't want to do this. You don't want the light away from the matrix band. You want the light as close as possible. Even though it looks bright, it's not curing the composite adequately. At the gingival margin, within the preparation, it's putting the tooth at risk for re-restoration. Light cure the adhesive for 20 seconds. When you light cure the adhesive, one of the problems that can occur is if the adhesive is pooled at the gingival margin. Look at the left-hand side. This is an extracted tooth where a composite's been placed, and the adhesive was allowed to pool and be thicker where it was up against the matrix band. It has the appearance of recurrent caries, versus air thinning the adhesive, not allowing it to pool, shows us that the composite's well adapted at the gingival margin. It sometimes leads to the incorrect diagnosis of recurrent decay. We're using a nanohybrid composite, placing the first increment of the composite in the proximal box and adapting it with an amalgam condenser that's been wetted with adhesive. If you're having difficulty adapting your composite class 2s, I'd recommend you put a little dab of adhesive in the proximal box. By putting that little dab of adhesive in a flowable composite, a little dab of flowable in the proximal box, and then when you place the next increment of composite, you won't trap air bubbles, that you'll have a nice blending of those interfaces. You do not cure the flowable composite increment in the box first. You cure the first increment of composite with the flowable simultaneously for 20 seconds. We add the composite, and for this case it was built up in 2 increments, adapted and shaped using a burnisher that's been wetted with adhesive. Each increment was light cured for 20 seconds, with the light at right angles and as close to and touching the matrix band. Here we're looking at the composite that's been adapted to the cavo surface margins. One of the things to note is that when you're placing class 2 composites that are slot preparations, your anatomy is going to be very minimal. We light cure 20 seconds for each increment with the light at right angles. We're making sure there's an orange shield on the light so we can look and stabilize the light. We have it as close as possible. All the rules of light curing we described in Module A of this series on posterior composites. We shape and finish using this finishing burr. This is the OS2 finishing burr with the rounded tip. I'm shaping and finishing and creating a distal fossa. For the proximal surfaces of overlap, in these areas you can see how broad the contact is. I'm going to use a disposable Bard Parker scalpel in number 12 and use that to shape and carve the composite before removing the rubber dam, taking care not to cut the patient's lip or their gingiva. The scalpel is very sharp. I'm then going to polish the occlusal surface using the enhanced polishing point, running it at 12,000 to 15,000 RPMs. That'll be my final finish for the composite. In some cases, I might polish using a diamond impregnated nylon brush instead of the enhanced polisher. And here we're looking at a diamond impregnated nylon brush that's reusable. Shaping the composite is very critical. Here I'm using a Bard Parker number 12 to remove any gingival excess and gingival overhang. I can also use it in the facial and lingual embrasures as we look on the left-hand side. Being careful not to injure the interproximal papilla or injuring the patient's lip or tongue. On the upper left-hand side, we see the preoperative view of the fractured marginal ridge in number 20 distal, and then the surface restored. It's not unusual that because of composite and it's difficult to, you can't physically carve it well, that the contact is usually broader than what we typically see with a natural tooth. Or for this circumstance, where we have a class 2 amalgam, that's a defective restoration. On the radiograph we see recurrent caries. We remove all the amalgam. We're going to be placing a glass ionomer liner on this axial wall because of its depth. Our preparation is mostly interdentin because it's all interdentin because we're replacing existing amalgam. We're using a hoe band, an extra thin, dead soft metal matrix. We pre-wedge the mesial and distal to get the separation to allow us to place the matrix. In this case I used an air self-etch adhesive rather than etching with phosphoric acid. I agitated it, left it in place for 10 seconds, air thinned it, and light cured it for 20 seconds. The light tips we have in the clinic would require that I light cure the mesial for 20 and then the distal for 20 with the adhesive. I then place the composite in increments and light cure each increment, and I finish and polish it. Notice the dental dam is in place. Isolation is critical for success with posterior composites. We can use a sectional matrix. You've had the experience of using the sectional matrix in preclinical. These rings put forces on the teeth to create rapid separation. We can use either the squarish bitine II or we can use the paludent bitine ring that's circular. We use the rubber dam clamps, rubber dam forceps, to place the ring on the teeth. We first place the matrix, and in order to use a sectional matrix, you must break contact buccal, lingual, and gingivally. We place the matrix, then the wedge, and then we place the ring in place. We need to be very careful and wary that the ring not go flying off the tooth, especially short teeth, because they're going to sit on top of the wedge. One of the ways to avoid that problem is to take a burr and cut the wedge using a slow-speed handpiece. In this case, we've cut the wedge, placed the matrix, and the ring is sitting more apical. So in this case, we're placing a mesial occlusal restoration on number 20 and replacing a defective fractured amalgam in number 19 occlusal buccal. We apply the dental dam and then we pre-wedge for separation. We remove the caries and the occlusal caries and the existing amalgam. No occlusal bevel, no gingival bevel. Preparations are now complete. We don't need a matrix for number 19, but we do need a matrix for number 20. In this case, we decided to use a sectional matrix band with a ring in place. The matrix is placed, then the wedge, and then the ring is placed. We etch the teeth for 15 seconds and rinse them for 10 seconds with air, water, or water spray. We dry the teeth, leaving the dentin glossy and the enamel frosty. We may decide to use a damp cotton pellet to moisturize the dentin. With a sectional matrix, it is critical that we burnish the band. In this case, we're using a 4th generation adhesive like the Scotch Bond Multipurpose, applying the primer for 5 seconds within the entire cavity preparation and onto the etched enamel surfaces. We then blow air for 5 seconds to dry the primer. We then apply the adhesive into the cavity preparation and we air thin it. We then light cure the adhesive for 20 seconds with the light at right angles and as close to the tooth as possible. We're using a packable composite for this, and there are special clinical techniques for packable. We want to use small increments, adapting it to the cavity preparation. We're going to use thin metal matrix systems like the Hoe band or the Paludent matrix. We're going to use a flowable composite on the gingival wall of the class 2, just a little bit placed, but we don't light cure it, and then we pack the packable composite to the flowable for improved adaptation. We place an increment no greater than 2 millimeters, light curing for 20 to 30 seconds for each increment. The darker the composite, the greater the light cure. Packable composites tend to be more opaque than our conventional nanohybrids. We light cure the adhesive for 10 seconds, and then here we're placing a flowable composite in the proximal box, just a little dab, a small amount. We then apply our first increment of packable composite into the proximal box, and we're going to build that up to the axiopulpal line angle. When we place flowable composites, different flowables have different radiopacities. And that's really critical to know because you're liable to look at something and you'll see a translucency. If you look at the middle tooth in the radiograph. These are extracted teeth. You can see the flowable looks less opaque, radiopaque than dentin, versus on the left-hand side, the flowable is almost as opaque as our restorative composite, our nanohybrid composite. Things that we need to understand about packable composites, we're only using them in the posterior. They came out because the manufacturers believed that to get dentists to change from amalgam to composite, they wanted something more opaque. They're not as polishable as hybrids and nanohybrids. They're more opaque in appearance. Hybrids and nanohybrids are more translucent. It's more viscous, hence the name packable. They must be pushed to be adapted. We're not syringing them into the cavity preparation and adapting them to the cavity wall. We physically have to adapt them. We place a flowable before the placement of the packable to make sure we don't trap any air bubbles, but it's also more easily sculpted when we're defining our occlusal anatomy. So we've done our flowable in the proximal box and we're placing our first increment of composite. I'm adapting it with my condenser. When I've built it up to the axial pupil line angle, I now light cure. The light should be at right angles and as close as possible. Now I put in my second increment and adapt it and shape the restoration and light cure it for an additional 30 seconds. Here's my second increment being placed for the entire occlusal. The light cured, and I'm keeping the light as close to the tooth as possible. And over, in this case, the mesial, I'll need to light cure the distal separately. One of the problems is you can still have gingival overhanging margins and potential periodontal problems. Just as in the case before this one, I used a Bard Parker disposable scalpel blade, scalpel handle, to shape and remove any excess adhesive, excess composite, and to help form my anatomic contact. I evaluate my gingival margin using dental floss. We evaluate proximal contact not just with dental floss, but we evaluate it visually. Visually, the composite must be in proximal contact with the adjacent tooth in the posterior. Just because floss catches does not mean that there is proximal contact. It only means that the contact is narrower than the thickness of the dental floss. We shape and the composite as previously described with our finishing burrs. We light cure the occlusal after occlusal adjustment to make the composite more wear resistant. For most routine size preparations for premolars and first molars, composite resin can be considered an amalgam substitute. We can use a packable composite, a hybrid composite, a nanohybrid micromatrix composite. They're all suitable for direct placement in the posterior. Posterior composite requires a high level of attention to detail to achieve clinical success through the multitude of steps and the requirement that we have good isolation. You've been viewing and listening to Posterior Composite Resins Module E on the Class 2 Preparations and Restorations.